Today, I am very honored to introduce to you our distinguished speaker. Dr. Leslie Waltke is a physical therapist with a clinical mastery in cancer rehabilitation and a provider of world-class cancer rehab program development, consulting, and continuing education. Since earning her degree in physical therapy from the University of Wisconsin in 1988, Dr. Waltke has dedicated her career solely to treating the physical needs of persons during and after treatment for cancer. Over the past decades, Dr. Waltke has cared for thousands of people with cancer and has a following of many beloved patients. She is respected nationally and internationally as an oncology physical therapist and cancer rehab key opinion leader, author, educator, and consultant. Since 2005, Dr. Waltke has been the cancer rehabilitation coordinator for our very own Aurora Cancer Care. Lucky us to have her. In her role, in addition to treating patients, includes rehab program development, program integration, education and training, and best practice and clinical standards development. A gifted and impassioned speaker, Dr. Waltke teaches and lectures throughout the world to rehab professionals, universities, providers, cancer organizations, and patients and survivors themselves. In recent years, she spoke at the China Cancer Congress and several World Cancer Congresses. Dr. Waltke is a former board member of the oncology section of the American Physical Therapy Association, an APTA credentialed clinical instructor for the Specialization Academy of Content Experts, and is a founding and current board member of ABCD Inc., or After Breast Cancer Diagnosis. She has received multiple honors for research, academic, and educational excellence. Dr. Waltke is a member of ASCO and ACE, the Association of Cancer Executives. And without further ado, I turn it over to Dr. Leslie Waltke.
Thank you, Kayla, so much. And thank you to you and Melissa for organizing this fantastic event. And to everybody, hello, happy National Nurses Week. So as a physical therapist, anyway, I have obviously a strong connection with nurses. I think that we have a unique medical background, that we have a foot in the medical world and a foot in the personal world. So we really just see patients in a very similar way, and that just brings so much benefit to the health system. What I want to do in the next 45 minutes or so is really dump kind of the old myths about what cancer rehab is and probably what you've been kind of used to. The old school ideas that, cancer rehab is just for people with breast cancer. It's just for people post-op. It's just for people that are only the people that are really struggling, or it's just a kind of a nice to optional thing for some people. We're also going to talk a little bit very quickly about the demographic changes that are happening in oncology, which I know you guys are all aware of, that are really driving the need for cancer rehab. So cancer rehab is not a fad. It is not going anywhere. It's going to become more necessary and more needed as we all move forward. And then ultimately, I want to talk about, what would a physical therapist do with somebody post-surgery, during chemotherapy, during radiation, to kind of really give you a good picture of what it looks like and how it functions, and how it integrates into the comprehensive cancer care team. And then we'll also talk about the power of exercise oncology and just exercising during chemotherapy. And again, how and radiation and in survivorship for sure, because we'll show you that the data is really clear of how powerful it is. Thank you, Kayla, for that wonderful introduction. I also want to point out, and I'll connect you at the end. I do have a YouTube and Facebook channel called The Recovery Room, and that is they're short, positive, easy to understand, medically accurate videos directed for patients. So they're about 4 minutes long, and they deal with some type of oncology topic that they can understand. And then I've actually recently launched a podcast called The Recovery Room Podcast. So I'll tell you more about that at the end. So let's just begin by connecting, because it's fair to say, what does physical therapy have to do with chemo, surgery, and radiation? So my favorite question is, why would a 82-year-old woman with fallopian tube cancer need a PT? That's a fair question. All right. And I will actually introduce you to her in a few slides. When we talk about cancer, people obviously talk about surgery, chemotherapy, and radiation. But once you go beyond that, you start hearing the words fatigue, pain, numbness and tingling, weakness, limited motion, balance problems, walking problems. All of these are very common sequelae of our cancer treatments. And this stuff is rehab stuff, OT, PT, and in some cases, we're going to pull in our speech and language pathologist. So if I had to put cancer rehab on one slide, it would really be that it's evidence-based. It is low risk, high value medical care that's reimbursed, that has been proven to improve outcomes for not only just the patients, but for our cancer centers. And we'll talk about that as well. So all people diagnosed with cancer deserve access to cancer rehab. So what do we do then? What is our job? From peri-diagnosis, now depending on what type of cancer somebody has, will kind of determine exactly when they slot into the rehab pipeline, but it's typically peri-diagnosis, okay? So our job is to assess and treat any musculoskeletal issues, any cardiopulmonary issues, any integumentary issues, so skin, connective tissue, and then also assess movement and functional issues. So ADLs, return to work, return to driving, return to activity. All of that stuff falls into our wheelhouse. So what I'd like to one of the big points I'd like to get across, first of all, is a very common question, a very clear question is, how do I know if I'm supposed to send somebody to rehab? And my question is, I don't know either. The only way I'm going to know if they need rehab is if they're on my table and I examine them. I do a subjective exam and a physical exam. Then I can determine, yes, this person needs PT, or they don't need PT, or if they do, they need a little bit now, or they need a lot now, or no, they don't need it now, but they're going to need it in 6 months. All right. So we'll talk more about that in a second. And yes, this is covered by insurance, no differently than if somebody had a stroke, if they had a knee replacement, or if they had a back surgery. Again, because for a lot of people with cancer, physical therapy is not kind of a common process. You know, like you have a stroke, you go to PT. You hurt your back, you go to PT. You get in a car accident, you go to PT. You get cancer, that referral is not typically there. So how people, nurses and physicians, script their language matters when you give somebody a referral. All right. So I like to say, because many of my physicians that I work with closely say that your cancer rehab consult is no more optional than your radiation oncology consult. All right. Because we know that it can improve outcomes and make the process better for the patient. So scripting matters. And I also want to point out that the cancellation no-show rate for our patients with cancer is really low. It is lower than neurology. It is lower than orthopedics, mostly because these people are fighting for their life and because of the massive benefits that people get from physical therapy, pain reduction, better walking, less fatigue, more control. So these people are really very, very good about coming into PT. So ultimately then, to make it easy on who to refer, is anybody that has been or will be exposed to surgery, cytotoxic or cytostatic chemotherapy drugs, and then radiation therapy. All right. So basically, that's almost 100% of our folks should at least get a consult. So we can look at their life, look at who they are, what is their starting performance status, what are they going to be exposed to, and how can we help that person through the entire process to minimize unnecessary loss. Is such an easy thing to do. And then again, absolutely increase their propensity to recover much more quickly. So outcomes are just so much better. So from a patient standpoint, the evidence-based benefits, quality of life, goes up. That's kind of a no-brainer. All right. There is strong repeated evidence that is, high quality, randomly controlled, double-blind studies that cancer survivors and cancer patients who exercise regularly, okay, live longer than those who don't. We don't know exactly what the mechanism of action is, but it could be that they have a better ejection fraction, they tolerate chemotherapy better, they stay stronger, they have a better performance status, but we know the data is there. We also know that cancer survivors and cancer patients who exercise during and after treatment through survivorship have a better overall survival from cancer. They have less cancer recurrence risk. They also have an improved overall survival from other mortality causes. So overall, all-cause mortality goes down and cancer mortality goes down. That is really, really a powerful tool. Again, that's low cost, low risk, and high value. Actually, from this started really getting studied most in the 1980s, was nursing studies. And they found very clearly that exercise and physical therapy helped to decrease anxiety, decrease distress and depression. And then that started to progress then in the 90s and 2000s into looking at, okay, can we decrease fatigue? Yes. Does it eliminate pain? Yes. Weakness, functional loss, all improve substantially with physical therapy. Now, for you medical oncology folks, you know that performance status and ejection fraction are they weigh a lot in somebody's care. So someone who is regularly in physical therapy, regularly exercising at home, will have an improved performance status and improved ejection fraction. And I will always remind people too that performance status and ejection fraction are modifiable. So if somebody comes in with a baseline crummy data, we can improve that a notch or two. We can also help either maintain somebody's body mass index or help them improve their body mass index. Because again, outcomes are not as good if people's BMI is too high or it is too low. And as I mentioned earlier, people are going to recover much more quickly after treatment if they've been going to PT and exercising throughout their treatment. So they're going to lose less and then have less far to climb once they get done with their treatment. Now, also, there are massive benefits to the health system when there is a good, thriving cancer rehab program. People, and again, this is all evidence-based, patients need to see their physician less often. There's shorter hospital stays, decreased readmissions, fewer falls. Patients actually stay on their chemotherapy delivery rates better. They have improved performance status. There's a maximized body mass and ejection fractions, again, which all help overall outcomes for the patient. And again, make the patient healthier and a heck of a lot happier and a lot less expensive. Okay, so let's take it one step closer. So cancer diagnosis typically leads to medical management based on type of cancer and stage. And it's that treatment then that results in the side effect profile. Okay. Now, depending on whether it's a head and neck cancer or a bladder cancer, they may have swallowing, language, breathing issues, pelvic floor issues. But in general, people are going to deal with fatigue, pain, weakness, limited range of motion, scarring, stiffness, edemas, neuropathies, bone loss, muscle loss, weight gain, weight loss are common, balance issues, cognition issues, sexual health issues. And again, this is our wheelhouse. This is what we treat. This is what we get paid to talk about with patients and take care of. So it's a nice adjunct to a cancer team. So ASCO did a study back in 2016 already. It was 16, looking at pain and fatigue and issues in survivorship. And they found that reports of cancer continue to be as high as 40% in our survivor population years after the treatment concluded. So their quote then is, chronic pain can be a serious negative consequence of surviving cancer. So even when the patient is done with cancer treatment, they typically will maintain a relationship with their cancer rehab therapist, whether it's OT, PT, or both, and or speech pathologist into the first years of cancer survivorship and beyond. We offer lifelong care to these people because we need to make sure that we can get rid of most of this stuff. So a few case studies here. This is a 46-year-old gentleman who was treated at a competing health system. He had was just literally just walking down the street, and his left femur just shattered. He was found to have a diffuse large cell B cell lymphoma in his left femur. So he underwent surgery, then had adjuvant radiation to the left femur, and then underwent chemotherapy. So the tumor and cancer responded phenomenally to treatment and just shrunk way beyond what physicians were expecting. So everybody's partying, everybody's happy. He rings the bell. He's just delighted. His wife is delighted. And then I get a phone call about 2 weeks after this bell ringing party. And I don't know where his wife had gotten our phone number from, but she said, so I don't mean to be disrespectful. I don't mean to be unappreciative, because we're very happy. She says, but this is Maurice. His cancer's gone, but you know what? He is still in moderate to severe pain. He can't stand very long. He is still grossly fatigued. His left knee doesn't bend for crap, which means he can't get up and down the stairs. He has trouble getting in and out of the car. His leg is really weak. He's basically numb from the knees down from chemo, so he doesn't walk well. He still has to sleep frequently throughout the day. So in general, and he can't go back to work. So in general, he just can't participate in the household. He's like, I don't feel like I'm a dad anymore. I don't feel like I'm a good provider for my family because I can't go back to work. He was just generally a really unhappy guy that just happened to be cancer free. So, and again, this is all stuff that was preventable. All right. At least much of it was preventable, or the intensity of it was preventable. If he had been in rehab throughout this, he wouldn't have lost half of this and would have been recovered much more quickly. So in his rehab program, you can see him standing on a balance disc here. So the reason his knee was not bending was because the soft tissues over his quad where he got radiated had basically just really solidified and shrunk quite a bit. So they just didn't have enough skin length to lengthen enough that he could bend his knee. The knee joint was fine. And we see this a lot in oncology, and we'll talk about this in our post surgery part of the lecture. All right. So we can't fix the neuropathy, but we can certainly make people's balance better. We can make their proprioception better. We can make them safer getting up and down the stairs. We put him on an aerobic program, sat him on a bicycle, got him on a walking program at home. He was doing sit to stand squats at home. He was doing push-ups against the wall, just building up his musculoskeletal strength, his cardiopulmonary strength. And then within about 3 months, he was able to, his pain was almost gone. His knee flexion was completely normal again. And he was able to get back to work, and his pain was gone. He was getting through the day without sleeping. But again, he shouldn't have had to lose half of that in the first place. So when I say preventing unnecessary loss, this is what I'm talking about. Another case study, this is Bill, and he had a stage 3 non-small cell lung cancer, and he was referred to physical therapy for the first time when his left arm swelled significantly. So he got a lymphedema in his left arm 3 years after the conclusion of his cancer treatment. And that's when he first got referred to physical therapy. All right, so this is Bill's right non-involved axilla. This is Bill's left axilla that was radiated for a lung cancer and regional lymph nodes. All right. So, and this is why his arm swelled. This was just thick, solid, didn't move well. He didn't move well. But of course, as a physical therapist, I'm not just going to focus on the swelling. I said, hey, Bill, it's been 3 years. Do you still have any fatigue? And he said, oh my God, it's moderate to severe. It's terrible. Yes, I still have fatigue. The range of motion in this shoulder was terrible. He maybe had 110, 120 degrees of flexion and abduction. Pain was mild to moderate. He said it's anywhere from a 3 to a 5. The more I use my arm, the more it hurts. So here he is, 3 years out of treatment. And as you all know, the 5-year survival rate for lung cancer is pretty crappy. So again, I treated his, I can't make that radiation fibrosis go away, but I can soften it. I can lengthen it. I can improve the range of motion. I can strengthen that arm. And literally after a couple days of stretching, the fluid in that arm just flushed right out. And we put him on a walking program, a strengthening program, a balance program. Again, super easy stuff that he could do at home. I think I even saw him just once a week, once every other week, just to progress his program. And in less than 12 weeks, his pain went to a 0. His range of motion went up to 160, 170 degrees. Strength returned back to normal, and fatigue was almost gone. So here is a man that really was dealing with crap that for 3 out of his potential 5 years that he didn't have to. And he's like, thank God my arm swelled, or I never would have gotten this care. So again, that's why we need to make sure that all patients are getting in to see us so we can treat this stuff and prevent it when possible. Oops, whoa, sorry. And again, the data is very, very clear. Rehab and fitness throughout cancer treatment interventions have been linked to improved outcomes, certainly for morbidity, but we've also talked about for mortality as well. So it's really, really critical that patients get in to see us. So from a side effect standpoint, again, local treatments, so your surgeries and your radiations. This is not an all-exhaustive list by any means, but pain, weakness, loss of range of motion, soft tissue dysfunction, and scarring are huge and are really important in post-surgical care, and I'll show you that. Swellings and edemas, risk for lymphedema, functional loss, incontinence, sexual dysfunction, the list goes on and on. Then from our systemic therapies, we work with fatigue, weakness, nausea, bone loss, muscle loss, difficulty walking, weight loss, weight gain, neuropathies, even people living with the arthralgias and myalgias from our aromatase inhibitors. We take care of all that stuff. But honestly, the 3 most common side effects that we deal with is fatigue, pain, and weakness. Those are the 3 most common complaints of cancer patients, and that is, again, a physical therapist's wheelhouse. So again, an evidence-based slide, regular aerobic and resistive exercise has been shown to decrease the risk of cancer recurrence. It's been proven in breast, prostate, and colon cancers. We think very strongly that it gives the same effect of decreased risk of recurrence in other cancers. It just hasn't been proven yet by the research, but we know that's coming. Regular aerobic and resistive exercise is the most effective treatment for cancer-related fatigue. That is really, really important. And the data show that only about 20% of medical oncologists or oncologists in general mention the word exercise. But we do know that when a nurse or a physician says the word exercise, the likelihood that the patient is going to do it skyrockets. So you are very, very powerful, and your scripting is very powerful. We don't expect you to teach people exercise or talk to them for, because you guys already crunched for time. We get reimbursed to talk to people about exercise because it's a lot, especially for people who've never done it before, or people that are pretty disabled, or just are, overweight, have a bad back, have crappy knees, or they're just trashed from treatment. Because no matter how sick somebody is, how old they are, they need to be on some kind of exercise. And again, we will modify it for that individual person. As we've mentioned, regular and resistive exercise decreases the risk of dying from cancer, and it also decreases the risk of dying from all-cause mortality. So again, one of my favorite slides is cancer rehab improves quality of life, length of life, and overall survival. So when we talk about now, let's shift to kind of what a comprehensive model looks like. And as I mentioned, exactly what type of cancer will determine exactly in the peri-diagnosis period that somebody gets slotted in, but typically somewhere peri-diagnosis. But what I think really makes cancer rehab unique is when somebody's newly diagnosed, they're staged and they will begin either chemotherapy, neoadjuvant chemotherapy, surgery, and every time they move to a new type of treatment, they end one team and begin with a new team. And what's nice about cancer rehab is they will keep their individual, again, it starts peri-diagnosis, and as the patient moves through the cancer treatment process and those different silos of care, that cancer rehab therapist will follow them throughout that entire months-long, weeks-long, or years-long treatment process, and then either into end of life or through survivorship. So, and that gives us the advantage of knowing what are they facing right now, what did they already go through that I might have to take care of, and what are they going to have coming up that I can take care of now to make what's coming up a little bit better. And we'll discuss that more in detail. Now let's shift to the increasing cases that we are seeing. So just with the increased population size and our increased population age is massively increasing the prevalence of cancer that we're seeing here in the US and actually across the globe. So again, cancer rehab is not going to go away. This cancer problem is not going to go away. So the less loss, the less medical intervention, the quicker people recover, the less expensive people are. It's just going to be better for everybody involved. Increasing population size, age. Again, for most cancers, their incidence is flat. Some of them are actually going up a little bit. We're having decreasing death rates, increased 5-year survival rate, plus all that stuff. Now adding on value-based care really is pushing a need for increased cancer rehab. So now what I want to do is kind of give you a general idea of what it will look like if a patient is going through rehab through the cancer process. So post-surgically, it's going to be very similar to what you would expect after a back surgery, an ankle surgery, shoulder surgery. What is different is the nice thing about cancer surgery is that typically surgeons aren't removing ligaments. They're not messing with cartilage. They're just taking out tissue and closing. So where an orthopedic surgeon will open the patient, fix something and close, a cancer surgeon opens, removes tissue and closes. So that does give us the propensity then to more often than not people to full pain-free preoperative function, competence, and comfort. Okay. With a little bit of rehab, it is very common that post most cancer surgeries that people should expect to become pain-free again. And we can't always promise that after a rotator cuff or totally replacement surgery. So, and we also want, again, because patients are going to go through an entire circle of care, that we want patients, regardless of what kind of surgery they had, should be educated in a lifelong exercise prescription because we know that's going to decrease recurrence risk. So I really work with my therapists to make sure that they offer lifelong care. So when you guys or whoever does the survivorship care plans for your patients should be adding the name of this person's physical therapist onto their survivorship care plan. So the goals for cancer surgery, again, are very typical to an orthopedic surgery. We want to improve post-op outcomes, decrease length of stay, keep them from going back into the hospital, keep them out of the ED, decrease the need for narcotics, help them maintain their independence. And another really important point, and again, this is all evidence-based, is that we know that transitioning patients from surgery to radiation or from chemotherapy to radiation, there's usually about that 30-day window. And in many of those transitions for many cancers, once you go past that 30-day window, outcomes, overall survival starts to drop a little bit. So by keeping patients healthy, keeping people moving, we can actually help ensure that people are going to be more ready for surgery after they've had neoadjuvant chemotherapy, or by getting people into physical therapy after a axillary dissection or a partial mastectomy or mastectomy, that they have the typical range of motion needed in 4 weeks to make sure they can start their radiation on time. So for a patient post-surgery, and again, it depends on where it is, whether it's the pelvic floor, if it's in the brain, around the larynx, we may need to work on breathing, or they take out a lung, we may need to work on swallowing, pelvic floor, cognition, language, balance kind of stuff. But in general, for your most soft tissue surgeries, we're dealing with pain, weakness, range of motion. So we are, doing range of motion exercises, we're doing strengthening exercises, we can get our hands on the patient and actually do some soft tissue work. I will show you how cancer treatment or cancer surgery can impact soft tissue length and soft tissue mobility, because we'll literally get our hands on the patient and mobilize that skin, either post-surgery and or post-radiation, to make sure that the skin has full flexibility, full length, and full mobility. Again, because that is probably where, when you talk about those 40% of cancer survivors that are still complaining of pain, most of that probably comes from soft tissue weakness and soft tissue restrictions that, again, a physical therapist could fix pretty quickly. So our goals, again, are to get rid of the pain, restore joint mobility, restore tissue flexibility, restore strength, get people back to their previous ADL, vocational and recreational activities, safely reintroduce what body part they had back into activity again. And in most places, we also work along with our nurses to help educate people in infection risk reduction and lymphedema risk reduction. A nice opportunity for physical therapists that work in oncology is if I'm seeing somebody for breast cancer, all right, and they just had surgery, but I know they had neoadjuvant chemotherapy. Now, really honestly, I should have been seeing them during neoadjuvant chemotherapy. But if they're seeing a PT for the first time, I'm going to assess their chest wall, but I'm going to find out, do you have any fatigue? How are your legs? How's your balance? Do you have any neuropathy? And I'm going to work on that stuff. So I can look back and make sure I can care for that part. I'm certainly going to treat their post-operative stuff. Mrs. Smith, I know that you have chemotherapy coming up, and we need to start you on a walking program now. Start strengthening your legs and your arms twice a week, because we know those simple things, even if we get to started a week prior to your first dose, you're going to do better. You're going to have less fatigue, less loss, less pain, less weakness if we can start moving. So anyone for their core, their legs, and their arms twice a week. And again, how simple that is completely based on how healthy is the patient, how old they are, what they have access to, but we can build things based on pretty much any scenario. And I'll show you pictures of this in a second. And I won't dwell on this a lot, but again, it's really important when I talk with my therapists to look at the soft tissues in the area of radiation and post-surgery. So we're looking at tissue length. Does that skin literally have the propensity to lengthen like it did before, so people can actually move their body parts? Are there layers of skin and connective tissue now that weren't touching before that now are, that can stick to each other? And in the case of radiation, if you've felt people post-radiation, you know that that skin can get really thick, which means it doesn't compress well, it doesn't bend as well, and it can be uncomfortable. So here is a rendering of somebody post-mastectomy. So this is a non-skin sparing, non-nipple sparing mastectomy. And again, so superior edge, inferior edge have to be pulled closed and sewn shut. And if somebody wants, and typically people want a nice aesthetically pleasing flat chest wall, so they may lose quite a bit of skin. And in this case then, when people don't have shoulder range of motion after a mastectomy or partial mastectomy, it has nothing to do with the shoulder joint. It's they've literally lost the skin length to get their arm over their head. Another issue to look for is, so now you're looking at a lateral view of a chest wall post-mastectomy. So here you have skin, and now you have skin laying right on top of pectoralis major. And this stuff can stick and can cause pain, and it can cause limited range of motion. Sometimes it can cause pain and range of motion is fine. So if people come to you and say, my range of motion is fine, I have completely normal strength, but it still hurts, there's still probably the culprit is here. All right, I just want to give you a little heads up. I'm now going to show you a surgical, intrasurgical slide of a chest wall. So here's that. So here is a left pectoralis major, literally about 30 seconds post-mastectomy. And then here's that same chest wall 365 days later. This is scar tissue, normal physiological process that you can't control, I can't control, patient can't control, medication can't control. So, but this patient was a patient of mine, and she's going back here for breast reconstruction, which is why they're reopening the chest wall. But zero, completely normal strength, completely normal tissue mobility, because she was moving during this scar tissue maturation process. So if it builds scar tissue, but it's not sticking layers together, it's not shrinking, it's not going to bother the patient. So it's critical to move patients throughout that. And then for patients at risk for lymphedema, and again, this holds true for the groin too. If you have that much scar tissue or that much compression or poor range of motion, either at the hip joint, for somebody who has a groin dissection or somebody who's had an axillary dissection, this soft tissue matters. Mobility matters. And that's why physical therapy has been shown to decrease the risk of getting lymphedema in the first place, because we can loosen this stuff up, strengthen the arm, return normal function, and all of that has been shown to decrease lymphedema risk. So this is Ray with colon cancer. This is a woman with ovarian cancer. Just trying to just lengthen the abdomen. We will certainly do strengthening stuff for people post-surgery. And ideally, I should have, again, treating even in the post-surgical realm with aerobic exercise as well, getting people on walking programs, stationary cycling, dancing, swimming, aerobics in the house, going up and down the stairs, doing something to get them moving. Now, from a radiation perspective, our job is twofold. During the radiation, the biggest side effects are going to be fatigue in the last couple of weeks, and then any desquamation or skin reaction and the related pain. And then long term, our job is to take care of any soft tissues restrictions that happen from the fibrosis and the pain and limitation that can happen from that. So again, during radiation, our job is to help minimize fatigue and functional loss by keeping people moving, shown to dramatically reduce the amount of fatigue related to radiation. Our job is to help make sure that we maintain range of motion at whatever localized joint where they're getting radiated, maximizing strength and helping maintain activity and engage in exercise. So as people get more tired, as they start to have more skin reaction, we may need to modify, but that's what we do during radiation. And then post-radiation, again, it's that slow setting cement of radiation fibrosis like scar tissue that we will follow people. And again, our ultimate job is, are you pain-free? Are you back to normal function? Is your energy good? Is your strength and soft tissue mobility good? And then make sure that people are on a long-term stretching program because of that fibrosis that shows up years later. So here is a post-mastectomy radiation. All right. So you can see her range of motion is fantastic and should be fantastic during radiation. But now our job is to keep it there. So she's already got the limitation post-mastectomy of already being tight potentially with the amount of skin that she's lost. And now over time, as this heals and fibrosis a little bit, we want to make sure that she maintains this range of motion so that she doesn't end up with any type of long-term pain or long-term limitation. So again, we use soft tissue. Certainly the patient's going to be on a stretching program, but we're also going to get our hands on their chest wall or their thigh. Here's somebody who had radiation to the left groin for melanoma. Her drain site got infected and stuck. So there was a big soft tissue issue here. This was hard as a rock from surgery and radiation. So again, getting our hands on there, mobilizing that tissue so people can move and feel better. Okay, so this young woman is receiving inpatient chemotherapy for leukemia and is my poster child that no matter how low somebody's blood counts go, exercise has been shown to be feasible and shown to be safe. Obviously, if they need to be protected from bleeding, if they're thrombocytopenic, they need to be protected from infection if they're neutropenic. But there are ways to make sure that people can stay active during chemotherapy because it's critical that they do so. The older they are, the sicker they are, the more important it actually becomes. So from a chemotherapy standpoint, again, we see the patient on an as-needed basis. We don't make people come in when they don't have to. We like to, because we know visit burden is a thing. So if we are a rehab clinic that is associated with a cancer center, you go in, get your blood drawn, come up and see me. We'll work for half an hour, go back downstairs. Your blood results will go back. They'll mix your chemo and off we go. If you have radiation today at 10, come see me at 10:30. All right. So again, we're going to build a cardiopulmonary and strength program specific for that individual patient. And we've talked about all the positive benefits of exercise during chemotherapy. And again, so the research is very clear. It's safe. It's beneficial. It's feasible. And we know that exercise should be encouraged. We know that it's safe with low blood counts as long as things are modified to protect the patient. And even in palliative care, hospice care, and even with advanced disease, as long as it is done by a physical therapist in appropriate ways for that particular patient, it is both safe and effective. And again, I mentioned this earlier that the best treatment for cancer-related fatigue is exercise. Now, here is your 82-year-old woman with fallopian tube cancer that I mentioned earlier. So she was exposed to surgery and chemotherapy for fallopian tube cancer. And she's 82 years old, lives independently. And, you dump chemo and surgery on a 35-year-old and they can need somebody to move in with them or they need to stop working for a while because it can just be really, really tough. So here you have this 82-year-old and she's independent, but like I said, she's marginally independent. and she was she was a hoot. She, she said, I love my children, but I do not want them to move in with me, and I am not moving in with them. She was very clear. So she sailed post-surgery, had little to no pain, and we put her on a home exercise program when she started her chemo. She walked twice a day for 8 minutes. She did sit to stand 5 times twice a day from a chair, and she did 10 push-ups against the wall. That's literally all it took to maintain her strength, maintain her function, and her cardiopulmonary status, that she was able to go through chemotherapy and stay in her own home by herself. Yes, family brought her meals and stuff, but she was able to maintain her independence. So when we talk about exercise prescriptions, technically, what the American Cancer Society says, the NCCN, all of ASCO, all the major cancer organizations, the American College of Sports Medicine, is during treatment, the goal is 90 minutes per week of combined aerobic resistive exercise for people who are in treatment. All right. If they do less than that, absolutely fine. If they do more than that, absolutely fine. Once you progress beyond treatment, that goal moves from 150 minutes to 300 minutes per week of, again, combined and resistive exercise. So aerobically, again, walking, swimming, running, rollerblading, dancing, Zumba, whatever people like is fine. Usually about 4 to 5 days a week, most days of the week, and then resistive exercise 2 days a week. And again, that can be something as simple as sit to stand from a chair for your legs, push-ups against the wall. For somebody who's older or who's just isn't going to do a lot. And if it's for somebody that's younger, we may give them 5 or 6 exercises. But again, the 3 lines at the bottom are lines that I use all the time with my patients. Anything is better than nothing. Slow is better than no, and sitting on the couch will never make people stronger. So yes, as you know very well, rest is more important. Rest is a tool to help people get through cancer treatment, but it has to be offset and accompanied with an exercise routine. So my favorite quote to end with is, if you have to be bald, we want you bald, smiling, and sweating. Because this does happen. This is fun. My cancer patients and I have more fun in the PT gym than everybody else. And again, there is such thing as a healthy cancer patient, but that does take the addition of a rehab team into cancer care. So really quickly before we go, I mentioned the recovery room. It's on, you can just type into the search engine, the recovery room, on both Facebook and YouTube. There's hundreds of videos there for patients. Launched a podcast called Recovery Room Podcast. Here's the first 10 episodes that have come out. Again, directed at patients. But again, I'm interviewing nurses and physicians and cancer survivors. And they're really fun. So what I'm also going to say to you guys is, I love talking with nurses. So if any of you or all of you say, oh my God, I'd love to be on your podcast, send me an email. I would love to have you on my podcast. So if there's something that you are passionate about when it comes to patient care or patient education, let me know. I'd love to have you on the podcast. It also is found, we have a video podcast version on YouTube. And then the audio can be found on Spotify, Apple, iHeart, all those places that you typically can find your podcasts. So I'm just going to put up this primary slide one more time, because again, it's evidence-based, low risk, low cost. My goodness, you can get an entire set of 10 sets of a good complete sense of cancer rehab for the less cost than one shot of Neulasta. So it's low risk, high value, low cost, reimbursed medical care with proven outcomes for both the patient and the cancer center. So thank you so much for your time today. Again, there's nothing I enjoy more than talking with nurses, physicians, and physical therapists. It's just my love, because you guys get it. And this is just another tool that you can use to make your life better, and certainly the lives of our cancer patients.
Leslie, what a fantastic presentation. Your expertise and your experience is so evident. And the fact that you are not only nationally, but internationally renowned in your specialty is just astounding to me. I know you shared a recent chapter publication that you have, so I will share that with everybody in the chat, and we'll see if we can attach that in our CME registration page for this session as well for any retrospective listeners. We do have a question from Sheila in the chat. She's asking if pre-treatment physical therapy prior to chemotherapy is ever an option, and if that's covered by insurance, because it's such a small window before we actually, the patient's diagnosed and we actually get them started on treatment. Is that something that you see, and does insurance typically cover that?
It does cover it. What we need for insurance coverage is, first of all, a consult is always going to be covered. And if somebody has a consult and we know they're going to start treatment, there's usually a problem list. So what we need is some kind of deficit, and that can be a knowledge deficit, can be an exercise deficit, or it can be a physical deficit they'll probably have, and then a medical necessity. So any cancer patients is certainly going to fall into those categories. And there is evidence. So for cancer surgeries, people that have lung cancer, prostate cancer, and head and neck cancers, we certainly want to see preoperatively because we know that their postoperative outcome is going to be better or likely to be better. When it comes to chemotherapy, the evidence also shows that the sooner they start, the better they're going to do. But like you said, often we only get a week. So sometimes we'll literally just call the patient and say, Mr. Smith, you start chemo next week. You need to start walking, whether it's a 5-minute walk around the block because that's enough for you, or whether because people tend to, if they are exercisers, they tend to stop once they're diagnosed. So getting people back. So yes, it is critical. And yes, that is covered. Thank you for that great question.
As we bring today's oncology nursing grand rounds to a close, I want to share with you a thought that I always carry with me in my work. And I know most of you do too, if not all of you. The heart of nursing lies in the ability to co-create and hold the space that is necessary for healing to occur. And this is where oncology nurses excel, every single one of you. So thank you for what you do each and every day. Thank you for your expertise, your professionalism, and compassion. Dr. Waltke, thank you for your presentation today and your collaboration with us as nurses. And thank you all for participating in today's presentation. Have a great night.
Thanks, everyone.